Welcome back. This is ER Medical Drama Critiques. If you're tuned into my channel for the very first time, my name is Dr. Taylor. I'm a board-certified emergency medicine physician, and I'm on staff at multiple different hospitals, ranging from small community hospitals to large academic trauma centers. In addition, I serve as a flight surgeon in the United States Air Force. Again, if you are brand new to this channel, I am taking a deep dive into every single episode of the PITT. We're going to be doing episode 10, part 1. Again, a detailed analysis, a deep dive. It's a critique, it's a review, it's educational. Literally, I am critiquing everything. Without further ado, let's continue reviewing one of the best medical dramas, if not the greatest TV medical drama of all time, The PITT, episode 10, part 1. Let's go.
Teddy, 28 years old, burned in a gas tank explosion.
All right, so a few things with this scene. For starters, to recap, we find this is Teddy. He's 28 years old, burned in a gas tank explosion. Now, we have a member of the flight team bringing him in, but we also have Langdon and Whitaker that were accompanying him. And it appears to be they were actually coming out of the elevator, meaning they were up on the helipad. Now, I've critiqued this numerous times. If it will change your management, then bring staff to the helipad. But in reality, it does not change your management. It is for dramatic television appeal that we go to the helipad. That, or you just want this awesome selfie. I'll put a few pictures of those on the screen. When I was on my trauma month at Shock Trauma, and our whole team, we were Team C, and we went up to the helipad. So I'll put that picture on the screen for you. But in general, you know, not just one person from the flight team is bringing that patient into the ER. On previous episodes when the MDMA overdose came in, there's actually 2 of them. In general, your flight crews are going to have a critical care nurse and a critical care paramedic, depending on the size, the flight, the distance, and the level of the team, right? Is this a shock trauma go team? Really a different situation, not going to talk about it. So in episode 9, part 1, you notice 2 of them. Here, there's just 1. So that's odd. Where is the other one? Doesn't quite make sense. Also, the downside of this is that when a patient gets into the ER room, report is given from, you know, whichever paramedic brought the patient in. Langdon already got report. Hello, the nurse needs report. Now, if you caught that scene, the nurse kind of showed up a little bit later, but kind of missed some of that report. And again, that's the disadvantage of this report that's always given in the hallways. And we typically see this actually in a lot of medical dramas. We'll see this report given in the hallway, and you're like, that's great, the doctor has the report, but where's the nurse, right? And so if we can get the nurse there to give a report, sure, I'll believe the story. But in general, they're coming into the ER, they're going into the patient's room, they're giving report to the nurse and to the physician. So in this case, they're just gonna have to repeat all of it. In a real case like this, the flight team would have brought the patient to the room. We would be waiting for them. The nurse and doctor would hear the patient presentation and we would take over care. Here, it's not the way that it was done, but again, I think it's more of a dramatic television appeal.
Paramedics estimate 90% BSA.
Trauma one's open.
We managed to get a 20 gauge on the right AC.
So paramedics estimate 90% BSA. That means body surface area. In this case, literally 90% of the patient's body is covered in burns. We also learned trauma bay 1 is open. Now, initially when I was reviewing this, I was like, all right, that's fine. Then I thought about it. Wait a minute, they're arriving, and then so we hear someone say trauma bay 1 is open. In a real case like this, we would already know that that bay is open. A patient like this would already be assigned a bed prior to arrival. In this case, the nurse comes up stating trauma bay 1 is open. And in reality, when the team gets there, they would already be told which room they're going to, and the team would already be ready. So overall, again, just kind of a few key things there that, again, the whole point of this channel is critiquing on a detail and level unlike any other. And I will point out absolutely anything that I find that is unrealistic or not 100% accurate. Am I gonna miss a few things reviewing this, you know, after watching a few times? Sure. Am I gonna skip a few things because of how long these videos are? Absolutely. But again, we're gonna critique on a level unlike any other.
First leader of LR running wide open.
Vitals are good. Pulse ox 97.
First leader LR running wide open through a 20 gauge IV. That is very realistic. We need aggressive fluid resuscitation here, and is a great choice of fluids for burns in this situation.
Teddy, are you in a lot of pain right now?
Not as much as I should be.
Anybody with 90% total body surface area burns talking like this is likely starting to have airway compromise. In fact, they already have airway compromise. When you have a burn patient, you know, one of the places that we look in first is actually the nose and mouth. Like, we're gonna gauge how that patient's talking, but we're looking at the nose, we're looking at the mouth. At this point, I'd be worried about airway edema. Actually, I can already tell you that patient has airway edema. They have airway irritation and the potential for getting worse. Absolutely. I'm really surprised here the patient was not already intubated, to be completely honest. Every flight crew member I know would have intubated this one prior to arrival in the ER, especially with this airway. I reached out to 2 of my critical care flight nurse friends that do intubate, right? This is what they're trained. They are trained to do this. And both would have intubated this patient prior to arrival in the ER, and both of them questioned why this patient was not intubated. Again, we're going to talk about this in a little bit, but I think that was a really key thing in this case is why wasn't this patient intubated? Now, did he just start talking like this as the helicopter was landing? Fine. I'll give the benefit of the doubt. We'll say patient was completely fine right when the helicopter landed, right before the patient got in the room. Or right before they got in the ER, the patient started talking like this. So maybe if I kind of twist it a little bit, maybe we can just give them the benefit of the doubt and say that is the reason why, but this patient should have already been intubated.
Okay. Mainly 3rd degree.
Singed nasal hairs, soot in the oropharynx.
Do you have family on the way? Amy, my wife,
What happened?
was transferring gas from a 200-gallon field tank to my tractor. Kaboom.
Singed nasal hairs. The big thing with a burn patient is looking in the nose and mouth, as I just mentioned. The patient has a raspy voice. They're talking softly. That's because their airway is about to close up. It's so edematous, they're about to lose their airway. If we do not intubate, I will crank this patient. If you do not intubate, you're gonna have so much airway edema, you will have 0 airway. The patient will go into cardiac arrest unless you intubate them. So in real life, if you wait any longer, you're gonna lose that airway. Now, obviously it's not a live reaction. I've watched this a few times, so we know they're gonna intubate in the ER, and we get a little bit of drama because the wife shows up, they get to talk, very sweet. And the residents are going to intubate, they're going to mention the meds they're going to use, and so we get to see all of that, and in reality, the patient would have already been intubated, and we wouldn't have any of that. We'll talk about that a little bit later, but again, I want to be precise here on what's realistic and what's not.
Let's set up for intubation. Whitaker, run the Parkland formula.
Okay, titrate morphine, Page Garcia, and I will be back for the intubation.
On it, boss.
Set up for intubation. That should already be set up. One, this patient would likely have been intubated en route already. So now that we got that out of the way, so I don't have to keep saying that. Obviously, in this situation, it can be a staffing issue, but this is life flight, and this is different. This patient would have been intubated. If not, the team would have actually stated why on arrival. Also, when we got this radio call that 90% burns was coming in, all right, this is in real life. If we get this radio call that we are getting a helicopter, 90% burns coming in, and they were not intubated yet. Obviously, okay, maybe something happened, there's a lot that can go on there. But we would already be ready to go. One, we would already know which room we're going to. Respiratory therapy is already present. The ventilator is ready to go. The nurse is ready to go. We have meds, we have stuff for lines. We are set to go. That's why we don't go to the helipad. We're in the room literally waiting for that patient to be brought to us. That's what happens. We're already ready in the patient's room, right? We're not meeting them in the elevator. So in this case, he states to set up for intubation, but this would have already been done. Like, I would literally have my meds ready to go. I would have, a couple ET tubes out. I'm already set to go. Again, I'm critiquing in a very detailed manner, but I'm explaining what is real and what is not. Now, Dr. Langdon states to run the Parkland formula. I love this, and I'm glad they address it. 100% realistic, 100% accurate. Patients with burns involving the dermis, superficial partial thickness, or deeper allows for significant fluid loss. So burns in general greater than 60% BSA have often been associated with cardiac output depression. So these patients need fluid as soon as possible. So the next question becomes, well, how do we calculate how much fluid? Whitaker's actually going to mention it, which is awesome, and that's the Parkland formula. So basically, this is looking at fluids to be given in the first 24 hours. Now, if you're a burn center, it's a little bit different. If you're, a hospital that's trying to stabilize a patient, start fluids, and then transfer to a burn center. But either way, you're using this formula. And so I'm going to put that on the screen for you. Total body surface area burned, percent, not counting first degree, times the weight in kilograms, times 4 mils per kg. So half of that is given in the first 8 hours. The other half is essentially maintenance over the next 16 hours. So when you calculate this out, realize, that's a lot of fluid, but also I think the caveat with this is, let's say you're seeing that burn patient at hour 2. Your fluids are when that patient got burned. So you may have to adjust that when you're, trying to calculate this out, realize, ooh, this is how far behind on the fluids we are, right? This patient, is 2-3 hours from when they initially got burned. So you have some catch-up time there. Most commonly, we use the Parkland formula, hence why it's mentioned in the TV show. So absolutely love this. I'm glad they mentioned this, and I'm glad it was very accurate. Now, a lot more things go into this than simply a calculation that I'm not going to go into detail with, but sometimes there is this increasing tendency to over-resuscitate during a burn treatment, so kind of keep that in mind too. Also realize that resuscitation of fluids is a guide here. You're still titrating to urine output, you're still titrating to tachycardia, you want to sustain organ perfusion, and then realize that the patients with inhalation injury or multi-system trauma may actually require more fluid. So kind of a few things to keep in mind.
Don't touch me. I'm fine.
Jesus fucking Christ.
It's okay.
Go, grab an ice pack.
I got the card.
What happened?
Just got punched. Just took a pull.
Who punched you?
Just an unhappy patient.
A patient hit you?
Yeah.
Happens all the time. Got my cheek broken.
I lost it too.
We've all been assaulted.
Go get Ahmad.
This should never happen to any healthcare worker. Honestly, anyone in general, but for this TV critique, for this TV review, for this medical drama review, right, we're talking about healthcare workers specifically, and this should never happen. It is a very realistic scene. For some stats here, and the fact that, this hospital is based in Pennsylvania, I actually took to the Health System Association of Pennsylvania for some stats. Off their website, it states 61% of all workplace violence happens in healthcare settings. Hospital staff are 5 times more likely than average to experience workplace violence, and hospital staff are much more likely to face workplace violence than workers in many other sectors. 13 times than food service, 10 times in retail, 4 times in air transportation, 2 times in transit, and 2 times in security. Goes on to state the Safe Healthcare Workers Act is modeled after federal protections for airline workers. It would establish federal criminal penalties. It is a federal crime for knowingly assaulting or intimidating hospital employees, with exceptions for individuals who may be mentally incapacitated due to illness or substance use. And I can already tell you Driscoll would not fit either of those categories. But overall, again, I just wanted to cover a few things. Again, this should not happen to any healthcare worker ever. So I'm glad that the PITT addressed this. This is very realistic. This happens, and this should 100% not happen.
Did you hit your head?
Hi. Probably, but no LSC, just a bloody nose.
I'll give pressure.
Okay.
Any trouble saying any double vision?
No.
I'll grab you new scrubs.
What about headache?
Yeah, a little.
You need to find her a room.
I do not need a room. Dave, move north one of the hall.
On my finger. Right. Left. Up. Down. Hey. Your arm was intact. Who did this?
He's a pissed off patient, but he splits. It's just again.
Again? Hell no. Look, I want a name.
Oh, we are not forgetting this in real life. There will be charges filed. This is 100% not acceptable.
Doug Driscoll.
The asshole in chairs?
Yeah.
Doug Driscoll. Obviously, he was mad about the wait time, but he was clearly not having an emergency based on repeated vitals within normal limits in normal labs. He would eventually be seen. Now, no patient should assault a healthcare employee because they were waiting too long in the ER, or literally for any reason for that matter. I'm going to mention this so many times. Violence against healthcare workers, healthcare employees, violence against anybody in healthcare is just not tolerated, and it should not happen.
Calling the cops. I'll get a wheelchair. Pupils are equal reactive.
I only pause here as I want you to watch how Dr. Robbie looked at the pupils, all right? Rewind it back and just watch, because it is spot on, and I want to compare that to what we see a little bit later with the neurologist. And so we often see this in TV medical dramas. Literally, we're going to have one of these pen lights, and we're going to see him kind of shine it in the eyes. They do it super fast. It's actually happened, I think, 2 or 3 times already in this TV series. I can't remember if I've commented on it or not. And the one time it was just like too fast. The other time they just like did one of these numbers. And it's just not realistic. Like if you're gonna do, a procedure, if you're gonna do something on a TV medical drama and you're advertising it as being realistic, then make it realistic. So look how Dr. Robbie did it right here with the pen light. It's very realistic, it's very believable, and we're gonna compare that to a little bit later with the neurologist. But again, I want you to be able to see that. So again, both of them should have been that way, but in this case, Dr. Robbie did it awesome. It looks believable, but you'll wait to see a little bit later and what the neurologist does.
No septal hematoma.
Should someone call your husband?
Absolutely not.
Okay. Tell me when it's sore. Tender at the nasal, CT head, maxillofacial.
I'll give them a heads up. They're really necessary.
You have at least one facial fracture with the headache and the fall. I want to rule out anything intracranial. Okay, who can step up for Dana while she's getting checked out?
Perla.
Thank you.
Ayokong gawin yan. Mas mabuti ikaw kaysa ako, no?
Okay, guys, we got about 3 hours left in this shift, and I need everybody to step up. Is that clear?
Yes. Yep.
3 hours left in this shift. You can feel it for sure. You get this far into your shift and think 3 hours left. On the one side, you're like, man, look how much has been done already. How many patients you've seen, the procedures you've done, literal whirlwind of emotion. And then you realize a lot can happen in 3 hours. Do you know how many times I've been in the last 30 minutes of my shift and we're hearing, we're getting a cardiac arrest, we're getting a trauma 1, we're getting a rollover, we're getting the patient dropped off at the front, multiple gunshots, or in this case, I'm gonna give specific example, very specific, but multiple stab wounds coming in because an individual with schizophrenia at a college party was knifing people. So in this case, we have 3 hours to go. Obviously, I've watched this whole series, so I know what's going to happen in the last few episodes, and I'm pumped for it. I'm waiting to critique this. I've been waiting to critique the last 3 episodes. I am super pumped to critique this. But again, we have to wait a little bit longer before we get to that point. 3 hours left in this shift. A lot of things can happen in 3 hours in real life, and this is very realistic.
I can't believe they allow you around med students, Langdon. And pick up any of his bad habits.
You know the difference between surgeons and serial killers? Serial killers don't bill their victims.
You guys staying ahead with his fluids?
Per the Parkland, 4 per kilo times 90% burned.
Wow.
27 liters over 24 hours. He's had 2 so far.
Lactated ringers, 1.785 liters per hour for the next 7 hours.
I'll program the pump. We got a second IV.
Hello, sir. I'm Dr. Garcia. I'm just peek under these dressings.
We ready to intubate? Wife should be here any minute.
For dramatic appeal, he's not intubated yet. That's literally the only reason why. In real life, even if his wife was on the way, this patient would already be intubated. Actually, I think I wouldn't say that again. I think I said earlier I'm not gonna keep saying that. I think this is the last time I'm gonna say that. The patient should already be intubated. You have 90% burns and your speech is at raspy and struggling. I'm gonna crank that patient for you if this doesn't happen. But let's still continue to delay this until we get a nice reunion, right? Let's bring them both in, let's show it on TV. But 100% not realistic.
Whitaker, earlier you said 3rd degree. We refer to burns as either being full thickness or partial thickness.
Looks like 60 to 70% full, 20 to 30% partial.
Intubation meds?
120 rock uranium, 100 ketamine.
Got it. Draw them up and hold them.
Vitals are good, but gonna need a pan scan after intubation.
Oh my God, no. Teddy. I mean, me and Teddy's wife. How is he?
He's stable for now.
I'm okay, honey.
Okay.
Teddy, you've got severe burns covering most of your body. You've also burned the inside of your throat. Just to be safe, I need to put in a breathing tube and you won't be able to speak.
We need to do this now before his throat swells and it becomes difficult for him to breathe. So if there's anything you two want to say to each other, this is the time to do it.
It's okay.
It'll be okay.
Can I kiss him?
Yes, of course.
Now, I will say it's great how everything is being handled in terms of the Parkland formula, the calculation, the fluid resuscitation, right? That part is great. It's just the actual delay and protecting that airway is the part that's not realistic about this. I'll likely get probably some non-medical individuals that are going to comment. All of the medical people, anybody that works in the emergency room is already going to say the procedure that patient should have already had, right? I'm not going to mention it again, but they would say it. I'm probably going to get a few people commenting that are non-medical, and they're going to say, Dr. Taylor, they're just waiting to do this so that, you know, his wife can say bye. They just want his wife to say bye to him. And I think it's important that you allow that. I don't think the patient should be intubated. Well, you're wrong. In this case, it's very sweet and all, but again, we're thinking of the airway. If you lose that, if you lose it, you're going to have to cut into the neck. I may even get someone else respond, well, even if you have to cut into the neck, at least he got to say bye. At least she got to talk with him. Again, that's not how this works, right? We're not just going to delay that just so we can cut it into the neck. Again, things don't come without a risk. So overall, this scene, it was a very good scene. Just a few things made it not 100% realistic.
Ready to intubate. Push ketamine, then rock.
Code stroke, emergency department. Code stroke, emergency department.
Ketavine's going in.
Okay, I will be right back.
The only reason I pause here is because we hear code stroke. Nearly every time in a TV medical drama when they cover a stroke, it's handled wrong. Either the wrong med is given, the wrong med is pushed, and it should be infused, or, my personal favorite, the patient immediately gets better. Great, did you just give TNK or TPA and the patient was having a TIA, right? They don't just immediately improve with a large vessel MCA occlusion, for example. Now, I'm still working on a live reaction to Code Black. I have finished the live reaction to The Resident. It's in the editing stage. I'm not sure when I'm gonna post that. Again, it's gonna be likely in between one of these videos for the channel, but currently working on a live reaction for Code Black. That is in the editing phase, and I went to town on Code Black. I don't want to give anything away, but it didn't go so well. The video itself went great. The actual review, oh man, I let them have it. So on the pilot episode of Code Black, for example, the resident actually pushes TPA. The patient immediately started getting better, just like that. They started talking. And if I was doing a live reaction of the scene that we're gonna see, you know, I would probably end up starting shouting at the screen and things like that. Overall, that rapid improvement is 100% not realistic. And part one we'll cover a little bit, but the majority of the stroke is actually gonna be in part two of this particular episode. So we'll get to that in a little bit. But again, I want to put that plug in there. Whenever I hear code stroke, I'm like, I already know what's going to happen. And I'm like, am I going to have to critique this? Is this going to be done correctly? And so I was very hopeful with this case until you start seeing that dramatic improvement. And you're like, yeah, that doesn't happen like that. Again, we'll talk about that a little bit later because I will mention it again.
Jane Doe, looks like she's in her 20s. Obvious aphasia, right-sided hemiparesis, and facial droop.
So here we have a stroke patient. We find out she's in her 20s. I think if I heard that right, she's in her 20s. So definitely a young stroke patient. But remember, strokes can happen at any age, especially those patients that are hypercoagulable, they have a clotting disorder, you know, something that we call a patent foraminal valley. And so these are things to consider as well. I'll never forget when I was a medical student. I was in my 4th year, so very similar to Whitaker, and I was in the ER rotating, and they had a 15-year-old that had a stroke. Right? A legit stroke. That same stroke you're going to see in a 70, 80-year-old, right? Literally a 15-year-old had a stroke. The mistake is to blow them off. Realize even kids can get strokes. So we learned here this patient has aphasia. So they lost the ability to speak. Again, it's a speaking issue. Again, is this receptive, expressive, right? There's a lot of different things that kind of go into this. But here, she lost the ability to speak. The patient has right-sided hemiparesis, so the right side of the body is basically just paralyzed. Now the big thing here is that we don't know how long the patient has been like this for. Last known normal is what we're looking for. This is huge as it changes what we can give in terms of, the patient being given a thrombolytic. Are they a thrombolytic candidate? Are they an endovascular candidate? And again, I'm not going to get into the timeline of everything. I'll mention it here in a little bit. But I'm not going to get into that in detail in terms of TPA timeline versus TNK timeline, got to extend a little bit, versus endovascular timeline and kind of what goes into that. But last known normal is huge here. So that's really the takeaway to get with this is what is your last known normal? And then also realize that even kids, teens, they can get a stroke. Don't blow them off.
Hi, what's your name? Nod your head if you understand.
Receptive and expressive aphasia.
No motor strength in the right arm.
Open your mouth. Gag reflex present.
Left motor intact.
BP is 150 over 88.
Where should we go?
IQ check is 73.
Straight to radiology.
100% realistic, and so far I am impressed, at least with what we've seen so far. This is a neuro exam in the hallway. They confirmed glucose to make sure this was not a hypoglycemic patient that can, when you get low blood sugar, it can mimic stroke-like symptoms. You find out blood sugar's 30, you give them an AMPA D50, stroke symptoms are gone, right? So the fact that they confirm glucose, they're seeing the patient in the hallway, this is one of those. It's okay to see them in the hallway. This is a much different situation because time is everything here, and we need them in CAT scan. So in this case, they even check the blood pressure, and Dr. Robbie mentions right to CT scan. Sometimes you may not get the story of last known normal from EMS. Family shows up later and confirms, oh, they were fine an hour ago. Oh, the patient was last normal 8 hours ago. Or the family was like, oh, we saw grandma for the first time. It's been 2 weeks since we've seen her before that, right? And your last known is like 2 weeks ago. So overall, time is brain, and we don't want to delay that. Even if T and K is being considered in this patient, we need them in CAT scan as soon as possible to make sure this is not a hemorrhage or anything else prior to giving them T and K. We need to make sure that they don't have a contraindication prior to giving them T and K, assuming they're a good candidate. A good stroke protocol, I'm going to say that again, a good stroke protocol is going to include the ER team seeing that patient in the hallway, doing your neuro exam. That patient then goes directly to CT scan. Literally, EMS arrives, they get seen directly to CAT scan, right? You get, a patient coming in, you want to still be seeing them before CAT scan because heaven forbid the stroke scale is super high, they've aspirated, they need intubated, they need an intervention, things like that. Otherwise, we need them in CAT scan. So overall, I love this scene. This is very realistic. This is the exact protocol that a few of the hospitals I work at do, so I love this. It was great to be able to see. Again, I just don't like the rapid improvement in symptoms that I'm going to see a little bit later. That's kind of like dampening everything because I'm like, this is so good how they're handling it, and then it's going to get ruined with that part of it. I'm trying not to think about it because so far it's a pretty good case, but let's continue.
CT brain without contrast, perfusion scan, CT angio, head and neck.
The images he states here are correct. A CT head without contrast, that is our stroke CT, looking for any essentially bleeding, anything obvious. And then CT angiogram, head and neck, that's evaluating essentially the vessels to see where the potential clot is. Again, it's going all the way down, right? It's a CT angio of the head and neck. We're going to see carotids, we're going to see, vertebral arteries, we're going to see everything. CT perfusion scan, which is basically used to help differentiate this salvageable ischemic brain tissue from damaged infarcted brain. But the big thing with this is, they did get the imaging right. I love this. Remember, time is a lot of things. Time is ovary, time is testicle, time is heart, time is brain. The longer you sit on these, the more difficult it becomes to salvage whatever it is.
So you didn't get a name on her?
We looked, couldn't find a wallet or an ID, but we had to jam out of there because it was a co-stroke. Who called 911? Well, apparently our Jane Doe is a professional gamer. She was a no-show for some big tournament, so her teammate in Dubai calls another teammate in Houston who called 911 here.
Who gets a stroke in their 20s?
That's what you get to figure out. Okay, come find me after the scan results are back.
All right, so we got a decent timeline with this, especially if gaming at that time, but confirming in this case would be pretty difficult depending on how that other individual is able to kind of contact whoever, so I'm not kind of sure, what's going to happen there. But the classic case I've seen is an individual calls grandma. Grandma answers the phone and it's completely garbled speech, right? They rush to her house. The concern is a stroke, rightfully so. She's got garbled speech. Call 911. EMS gets there. They're going to ask, what's the last known normal? Some answers you get, the family will state, oh, just 30 minutes ago I spoke with her and it was garbled. Well, in the ER, we're going to say, no, when is the last time that grandma was normal? Right? We have to be very specific on that question. I can't tell you how many times that last known normal was asked. It was basically asked incorrectly, and you have to almost rephrase it. And so it's very similar to like nursing home patients. We'll get a stroke patient come from the nursing home, and EMS is going to say last known was an hour ago because that's what they heard from the nursing home. And then you call the nursing home. It turns out they rounded on the patient, woke the patient up, and they had stroke symptoms. Wait a minute. So that means the last known was probably sometime last night, right? Not that morning. So in the ER, we're going to say when is the last time anybody has, in this case, heard or seen grandma normal, and you find out it's been days like this, right? Grandma went days like this before you finally call her. Or, for example, grandpa goes to sleep at 8 p.m., right? Wakes up at 6 a.m. to stroke-like symptoms. His last known normal then would be 8 p.m., so 10 hours prior to arrival before coming in. So every now and then you also run the situation where they went to bed at 8 p.m. and you're like, please, I hope they woke up during the night, right? Maybe that, enlarged prostate, they had to wake up to go pee, and you're like, it's one time you hope a patient has enlarged prostate, right? I had that same patient. They got up to pee at 5 a.m. and felt fine and then went back to bed, right? And then they're coming in a few hours later. So now their last known normal is just a few hours prior to arrival. It's a little bit different situation, but that's why it's so important to get a good timeline.
Harrison? Hey! Hey! Are you okay? How'd you get here?
With Dad.
Chad Ashcroft, 39, skateboarding accident. Deformity of the right ankle, no LOC, good vitals, got 4 of morphine en route.
So let's talk about that EMS report. Short, sweet, to the point. That is what I like. That is what any ER doc likes. I've mentioned this on previous critiques. A good EMS report is 1 minute or less. A few of the hospitals I work at, we actually have a sign for EMS. It's literally in the ER where the EMS goal report is 1 minute or less. And that is on arrival, giving a report to the nurse and doc. So in this case, we have a 39-year-old skateboarding accident, and we hear deformity to the right ankle. Please keep that in mind because there is no deformity. I think they just missed this when they were filming and just that part, but there's no deformity here. But anyway, we learned deformity of the right ankle, no LOC, so the patient never passed out, good vitals, and 4 milligrams of morphine was given. Now, I've critiqued this before. Don't tell us good vitals. Now, I'm one of the EMS medical directors for my Air Force base, and I've had this discussion numerous times when I'm reviewing various cases. You do not say good vitals in a report. Good vitals mean different things to different people. Tell us what they actually are. Is good to you a heart rate of 55? Is it 90, right? Is it 102? What blood pressure is good to you? Is it 110? Is it 180? Right? Side note, but more concerning is, take for example, we have a trauma patient come in, and we're going to get extravagant on this one only because I've had this exact same one. You get a patient that, let's say they're 450 pounds, they're on 40 medications, right? They have a history of high blood pressure. Normally, just for the blood pressure alone, they're on 5 medications. They have congestive heart failure, COPD. Let's say, it's renal failure. The list goes on and on. They smoke 4 packs a day, uncontrolled diabetic, and you find out they're non-compliant. They go off all of their medications. And they come in after a rollover and you hear vitals good from EMS. You get them hooked up, blood pressure is 110. I ask you, what's wrong with that, right? There's so much wrong with that because to be on all of those and then to be on that many blood pressure medications and not taking them, there is no way that blood pressure is 110. Realistically, it could be 190, 200, 210, 220. It could be much higher than that. So the big thing with this case is realize that this is a relative hypotension. You're going to start getting a number of 110. In my mind, I'm like, this is a relative hypotension. There could be some underlying, occult shock there. So that's why it's important. Just give me the vitals. Just tell me what they are. Or heart rate is good and you find out it's 90. It's actually, grandma or grandpa with a GI bleed, they're on a beta blocker and their heart rate's 90. That's actually tachycardic because what's happening is that beta blocker is actually masking the effect of that tachycardia. And so I can't tell you how many times we're going to hear this. Vitals are good. That doesn't mean anything. Give me the actual vitals. And I keep putting that plug in there because I think this is the second time, maybe the third time I've mentioned this within this PITT series. So tell us what the vitals are. Don't say they're good. I'm going to call this out every single time. Also, if they're going to say deformity, right, any good EMS paramedic is also going to state if the patient is neurovascularly intact. Any good paramedic is going to say that. If you're going to come in and say, patient's got an obvious deformity, absent pulse, diminished pulse, or, bounding dorsalis, just give us something, right? They're going to give you they're going to tell us the neurovascular status. Here, I didn't see it. I played it back a few times, like, I didn't hear them say it at all. So in this case, that becomes important. Now, I don't know one paramedic that, again, would state deformity and not check a pulse. They're gonna check a pulse. So also, I want you to hear it now before it happens, as this case ends up being 100% not realistic, and you're gonna see why. Starting with visually, you can see there's clearly no ankle deformity. In fact, I'm going to put a bunch of ankle deformities on the screen for you, just so you can take a look at that. Obviously, everyone's going to be different. But what made this start to be not realistic is, one, you get some of the EMS report, good vitals, and then you don't hear anything about a neurovascular status. Then you hear there's a deformity, but then there's actually no deformity. I mean, look at that leg, and I think it was episode 1 or 2. It was a degloved leg. Holy cow, that looked real. That looked legit, right? There was an obvious deformity there. So clearly we have the ability to do that, and here we don't see any deformity. So part 1 is only going to cover half of this case, and part 2 is going to cover the rest of it. But please keep this in mind later when they start talking about treatment. And then a little bit later in this episode, we're going to talk about some of the things that they're saying that doesn't quite line up and doesn't quite make sense when it pertains to that treatment.
Skateboarding, really?
I'm fine, by the way.
You know this guy?
Unfortunately. Looks trimalleolar.
Oh, for heaven's sakes. Dr. Collins states, looks trimalleolar. No, that's not one that is said multiple different ways. It's trimalleolar. Literally, you have a medial malleolus. Sometimes we'll say medial mal or lateral mal. You have a medial malleolus and you have a lateral malleolus. When you have a break in 3 spots, you're going to say trimalleolar. If it's 2 spots, it's going to be bimalleolar. That us gets dropped. Even a medical student or intern would not state this. So this actually may get back to that point I've spoken about before of making sure the year in residency matches the degree of medical training. Overall, I'm really surprised the consulting physicians or whoever watches this to make sure the actors and actresses pronounce things correctly did not pick up on this. Trimalleolar is not a thing. Nobody says that. So again, that should have just been corrected. Also, I can already tell you on an ankle like this. Now, we know that it doesn't have a deformity, and we later know that reportedly it's a trimalleolar fracture, but we don't say it looks trimalleolar. Could this be one isolated fracture, right? It's just the distal tib or it's just a distal fib, or is this truly, in fact, it's got that third mal in there, so it's a trimalleolar fracture? Absolutely, but already this scene is not realistic. Now, we're going to get x-rays to confirm this. Now, if someone has an obvious fracture, right, let's say that ankle is a 90-degree angle, literally just looks messed up, and I'm going to put some messed up ones on screen for you. We can state patient likely has a possible trimalleolar ankle fracture. So take a case I had last week. Patient falls down the stairs. Both the medial and lateral malleolus was significantly swollen. Patient is neurovascularly intact, bounding pulses. I do have a rest of the exam that I'll typically do, talking about Liz Frank, talking about base of the 5th metatarsal, the navicular, Thompson, tenderness along the Achilles. There's a lot more that goes in that physical exam, but specifically talking about the soft tissue swelling of the ankle itself. And I'm going to tell the patient, we're going to proceed with x-rays. Given the amount of pain, given the amount of swelling, I'm highly concerned you have an underlying ankle fracture. They may say, oh, doc, am I going to need surgery? Well, let's just start with the x-ray first and know what we're dealing with. I'm not just going to go up to a patient and be like, without an x-ray, looks trimalleolar, right? Nobody says that. Nobody does that. Again, this is a senior resident. I'm going to critique this every single time because it's just not realistic. I would argue it's an amateur move and not something a senior emergency medicine resident would have stated. So putting the pronunciation of trimalleolar out the window, not even talking about that, again, I would argue it's an amateur move. It's not a senior emergency medicine move to state to somebody, looks trimalleolar, and you actually didn't see an x-ray first. Amateur move.
We'll be at the hospital for dislocation.
You think I want to be in this shithole? I told him to take me to Presby.
You were the closest hospital, so here we are. Where should we put him?
On the curb?
Are you two family?
X.
This is Chad, Harrison's dad.
Nice to finally put a face to a name. What's open?
McKay, stay with your kid. Let's take this half-pipe Prince to South 19. Hey, what's the golden rule?
No hospitals.
Okay, let's add no skating without a helmet ever again. You hear me?
Yes, Mom.
When's the last time you took a bath? Where's Robbie?
Intubating the burn patient.
Ma'am, can you close your eyes for me?
Robbie, it's Samira. The endo CT came back. No bleed, but there was a carotid artery dissection left neck with a thrombus that threw a clot to the left middle cerebral artery. Okay, got it. We'll wait.
So imaging shows no bleeding on the head CT without contrast. CTA head and neck shows a carotid artery dissection on the left. So it's a left carotid artery dissection with a thrombus within the left MCA. Now, I'm also going to put a few images on the screen for you that really kind of show what that looks like. Now, these images and results that in this case they get back, they come back fast. This is not just a regular CAT scan, especially you have a stroke activation CAT scan. These CAT scans are read immediately. Because it's a stroke activation, a radiologist is going to get them. They're going to read it immediately. Generally, they're going to read it immediately. Sometimes it can take a little bit, but they're going to read them very fast. And they're actually going to give the ordering physician a call, a direct call with the results. They're going to call them criticals. And they're going to give you a call back. You're going to discuss it with the radiologist, and you're going to get that before the actual formal report. So in a residency program, with that resident getting the results, the attending then gets updated like this. That part is very realistic.
With no intracranial hemorrhage, she might be a TNK candidate.
But couldn't TNK cause a brain bleed and kill her?
TNK is still the best clot busting possibility.
Shouldn't we do endovascular therapy? I mean, that's the safest option.
So TNK or tenecteplase is used for an acute ischemic stroke, just like what they're given here. So the American Heart Association had a great article entitled A Systematic Review of the Efficacy and Safety of Tenecteplase versus Alteplase in an Acute Ischemic Stroke. A time to pass the torch, the article states. So we're going to go through kind of a few of these. This one goes on to state that tenecteplase is a modified form of alteplase using recombinant technology. Has several pharmacological advantages over alteplase, including longer half-life, higher fibrin specificity, and greater resistance to plasminogen activator inhibitor 1. Additionally, tenecteplase is given as a single bolus administration compared to the bolus plus an hour continuous infusion of the alteplase. Tenecteplase has become an alternative thrombolytic for the management of acute ischemic stroke. So that was one of the initial articles, and then we're going to kind of say what kind of progressed since then, because at one point, TPA was the only FDA approved for an acute ischemic stroke. So in terms of that FDA approval, we mentioned on Monday, March 3rd, 2025, the FDA approved Genentech, so that's the company behind it, TNKs. They approved Genentech's TNK in acute ischemic stroke in adults. So it became the first stroke medicine approved by the FDA in nearly 30 years. So what is also interesting is that Genentech has developed now the only 2 FDA approved medications to treat ischemic stroke, both TNK and TPA. So off of Genentech's website, specifically they state TNK is a tissue plasminogen activator, clot dissolving thrombolytic medicine. TNK is administered as a single 5-second intravenous bolus. The TV show, I think if I recall, they stated 10 seconds, so I'll let that slide. I'm like, that's not much of a difference. But anyway, 10 seconds. And starts a biochemical reaction that can break down fibrin, a component of blood clots. The most frequent adverse reaction associated with tenecteplase or TNK is bleeding and hypersensitivity. So TNK is now indicated for the treatment of acute ischemic stroke. That's why it's used here. That's why it's in MRAP. That's why they're using it in this TV medical drama. So I absolutely love this. Now, this is also interesting why the pilot episode of Code Black, you actually see TPA being given, and that's because, with the year that was filmed and everything, TNK wasn't being given. That wasn't the standard. So when I critique it, I have to critique based on the year that it was. So I just want to put that little caveat in there. If people watch it and they're like, why are they giving TPA in this TV medical drama instead of TNK, or why are they giving TNK instead of TPA? And that kind of has to do with the timeline. Overall, all the hospitals I work at, TNK is now used, so very realistic. I love this. Now, after this is given, and you're really having that discussion as well on endovascular intervention to remove that thrombus. So Dr. King actually states, should we just do endovascular? No. In the case of a clot like this within the MCA, especially when you're still within an endovascular window, the patient's going to end up with TNK and endovascular intervention. You're not getting one, you're getting both of those. Especially, in this case, we don't know if they even have endovascular ability at this hospital. One of the hospitals I work at, we're going to give TNK, and then we're actually going to transfer to another hospital that has endovascular capabilities. I think it's a little bit different situation if you're at one that has both. But some hospitals give the TNK, and then they're going to transfer to a place that has endovascular capabilities, and they'll do the retrieval, but patients are getting both. Does this TV medical drama have endovascular capabilities? I don't know. I would assume maybe they do, because they seem to have a lot of different things, including ECMO, and we're going to learn later they even have Reboa, which I cannot wait to talk about, because I disagree with what happened. Overall, we're not quite sure what this facility has the capabilities are, or what their capabilities are in terms of endovascular intervention. But again, it's TNKs being given, and then it's going to be endovascular retrieval.
What do you call a Tyrannosaurus under stress?
What?
Nervous Rex.
Dr. King, meet Dr. Mehta, one of our esteemed stroke neurologists.
See what I mean about the pen light? I told you it was going to be quick. That was so fast. He saw nothing. Again, if you want to show that part of the neurologic exam, especially coming from a neurologist, for the love of humanity, show it correctly. Otherwise, just don't show us this. What's the point of doing this? You're not going to be able to check pupil size. You're not going to be able to see anything. Dr. Robbie at least made it look believable earlier. So why not make it look believable when the neurologist does it? I just don't understand that. I think we need continuity across these episodes in terms of making things look believable. If you're going to do something, just do it correctly across the board, or just don't show us. Don't show us that part of the exam.
How's the patient?
NIH stroke scale of 27, no last known well time.
Stroke scale 27. Now, you may even hear someone say, what's your NIH scale? That means, they're asking you, what is the National Institute of Health stroke scale score? Basically, using a numerical scale to determine the severity of the stroke. So healthcare providers record that person's performance in 11 categories. Again, I'm going to put these on the screen for you, such as sensory and motor ability, for example. Now, I'm going to show you an example on screen showing specific instructions used to correctly determine performance in the scale scoring for category 1A specifically. Now, to do the entire stroke scale in this critique would take a long time. In real life, actually doing it just takes a minute or two. That's it. That's how fast this is done. So we're looking at level of consciousness in this example ranging from 0, which is alert and keenly responsive, to a 3, which means the patient only responds with reflex motor or autonomic effects, or is totally unresponsive, flaccid, areflexic. Obviously, the higher the score, the worse the stroke. So realize this is just loss of consciousness part of the NIH scale. We're not going to go through obviously the entire stroke scale, but I wanted to show you at least this part of it in terms of some of the numbers and the grading when it pertains to 1A. Again, I'm going to put the rest of the stroke scale on the screen for you to give you an idea. Feel free to pause. I know there's a lot there, but just to kind of show you at least what we're seeing on the nurse and doc side of things, the neurology side of things, when we're seeing these stroke patients, what we're actually recording, what that number means. A stroke scale of 27 is high. This is a legit bad stroke.
Dr. Mehta, should we take her to EVT?
EVT. So that stands for endovascular thrombectomy. Per the University of Florida Health, endovascular thrombectomy, or EVT, is a minimally invasive surgical procedure used to treat acute ischemic stroke. So EVT involves the removal of a blood clot from a blocked artery in the brain, and that can restore blood flow and prevent further damage.
Not yet. Take first spin in the MRI. Check for irreversible damage first. There's a diffusion flare mismatch. She's still in the window for thrombolytics.
And she still gets EVT. 2-for-1 special.
What type of person is best suited to work with an MRI machine?
A trained technician.
Someone with a magnetic personality.
That one's new.
How they perceive neurology here is spot on. I love this. I can already compare that to a few neurologists that rotate. So spot on here, very realistic.
So, somebody punched her?
A patient broke her nose.
Is she okay?
Robbie checked her out, sent her to CT.
Sorry to interrupt the hot goss, but what about me?
You got some pretty good cuts here, sir. We're working on closing them up to prevent infection.
Yeah, can you call in a plastic surgeon? The lacerations aren't that deep. Medical glue should do the trick.
Plastic surgeon for an abrasion? Come on, dude. Don't insult plastic surgeons. Those abrasions don't even need glue. I would not recommend that anyway. That is simply a dressing after cleaning, monitoring, possible oral antibiotics. If they're not updated on tetanus, we're updating that. You know, overall though, seriously, dude, you want a plastic surgeon for an abrasion? You gotta be kidding me.
Have any extra? Do you want to maybe apply some to his lips? Your son was worried about you. I wanted to make sure you were okay.
Are you okay?
Yeah, totally. Just a few battle wounds.
Did you hear? Dana got assaulted.
What?
Yeah, patient broke her nose.
When can I get out of here, please?
We're waiting for radiology to come down with a portable x-ray machine so we can take a better look at your leg. You'll need a splint and eventually a cast.
Ah, you hear that? Your dad's gonna have a cool cast.
Now, we're gonna need a splint and eventual cast. Not bad, but keep that in mind for later in part 2. Again, when she says splint and eventual cast, keep that in mind for part 2.
Big Harry in the house, up top.
Mateo! I told my dad that we went skateboarding last weekend. So he took me today, and then he fell and broke his leg.
Yeah, I can see that. Hey, man, Mateo.
Hey.
Want to go raid the break room with me? I hear there's a bag of Takis with your name on it.
Sure, yeah.
But not too much sugar.
Doesn't matter if it's Captain Crunch for breakfast.
Not anymore. Chloe makes me an acai bowl every morning.
Oh, Chloe. The gift that keeps on giving.
I already apologized for that.
How are those nuts coming, Dr. Santos?
Good. All done.
We'd go check on radiology.
I'll come with you. Sooner we get you in, sooner we get you out.
Thank you.
Pause here for a few reasons. Remember earlier, Dr. Collins states trimalleolar, right, when it's actually trimalleolar. And we hear EMS say obvious deformity. There is no deformity. This x-ray is hard to see, but I can see a fracture. I'm going to put this on the screen for you. Again, look at this x-ray. I can already tell you based on the x-ray, there's no deformity here. It's almost like what they wanted it to be. They wanted it to be a deformed trimalleolar fracture, but then the physical exam they gave us, right, they could have used a prosthetic or something to give that appearance. So those two things didn't match. And then they confirmed it when they actually put the x-ray up there, and you're like, clearly there's no deformity even on the x-ray. This is a distal tib and distal fib fracture. Sometimes that third fracture, we call that third mal, you actually need the lateral view to be able to see that. So she's actually going to ask for that in a minute, and I'll pause. So that part made it realistic when she asked for that view, because I'm like, man, if you're going to get so specific, that's actually, because again, side note, one thing I'll often see is you'll have like an intern that'll be like, yeah, I have a bimalleolar fracture. Radiology hasn't read it yet. Or let's say, you know, you're an ER that doesn't have radiologists that read x-rays. That was the case for my residency. Radiologists would read the CAT scans, but we read our own x-rays. And you get an intern that's like, hey, I have a bimal, you know, ankle fracture. And like, did you look at the lateral view? And then you look at the lateral view, there's the third mal. This is actually a trimalleolar ankle fracture. So rookie mistake. I did that before. So that's a big thing with this. And so for her to say, what's the lateral view? But then early on, just, you know, all that stuff didn't quite line. Oh, you have a trimalleolar fracture. It doesn't add up. We need that continuity for these senior residents. Overall, they just needed a different x-ray to make this believable, and also someone to show a different leg to make the deformity believable.
Distal tibia and fibula with an unstable mortise.
Hold on, show us the lateral, please.
Here you go.
Not 2, 3 breaks.
Jesus.
Again, props that she asked for the lateral view to show that potential third fracture and the completion of that trimalleolar ankle fracture. Hope you realize certain things did not quite line up. I would have rewrote this scene much different. We would have had, you know, a leg that actually looked deformed. We would have put a much better, we would have put basically a different x-ray on the screen. We would have made this believable. In part 2, we're going to talk about the treatment and what happens with that. I also would have changed that one as well. So again, I just want to put that plug in there. Overall, good scene. It's just not 100% realistic or accurate.
Wait, so now I got a cast?
No, a splint
And surgery to stabilize the bones with plates and screws so they can heal properly.
How long am I gonna be stuck here?
That is above my pay grade. Gabriel. You may want to cancel any dinner reservations you may have. Set up for a double splint, posterior leg, and sugar tongue.
Well, is that gonna be painful?
There may be some discomfort. I assure you, we will prescribe proper pain medication to provide you with adequate relief. Drop 100 of propofol, 50 of FUT.
Whatever, just knock me out.
With pleasure.
Oh boy. So this may be the most, I think, unsafe thing Dr. Collins has stated, and I 100% disagree with this entire next part. Here she states, draw up 100 milligrams of propofol. Now she's saying draw it up. Just because you draw it up doesn't mean you're going to give 100. You're going to give 20, 50, whatever. You're just going to have it so it's ready. So she states to draw up 100 milligrams of propofol. We don't know how much is given. We later do. But now we use this for sedation, for procedural sedation. This patient has a fracture and they need a splint. But I can tell you from doing 100 plus of these, you do not need 100 milligrams of propofol. In fact, you don't need propofol. That would be an official procedural sedation, cardiac monitor, respiratory present. If the patient had a trimalleolar fracture with dislocation, that's what you actually do the procedural sedation for. You're going to undergo this formal sedation process. You're going to reduce the ankle. You're going to splint it. In reality, in a patient like this, you're going to give morphine, you're going to give Versed, even Dilaudid. Sometimes you can actually give them a pain dose ketamine when you place the splint because it's going to hurt. But realize, they're not having to adjust the ankle here in this TV show. I cannot stress this enough. All they're doing is literally lifting the ankle and placing the splint. You don't need 50 of prop. You don't need 75. You don't need 100 milligrams of prop for that. Now, if you had this deformed ankle and you want to do the procedure and the reduction and give the propofol and do all that, that's fine. But propofol is not giving it. It's 100% not realistic. Literally holding it up and splinting. We have options. The patient needs a splint. They don't need a reduction. There is no reduction happening here. You do not need 100 milligrams of propofol to place a splint on an injury like this. This is completely inappropriate and not recommended. Any resident watching this right now, again, any resident watching this right now, do not do this. Do not suggest this. Again, I realize that placing a splint can be painful, all right? That is why we give pain meds, but we don't do a formal procedural sedation like this. Or if you're an intern, right? I won't say second or fourth year EM residents because even they won't do this or ask this. But ER interns watching this right now, all right? ER interns watching this is just for you. Next time you have a patient, make sure it's a cool attending before you say it, right? If you get a really serious one and you ask this question, he may just lay into you. So be careful with who you ask this question to. But next time you have a patient with a reported trimalleolar fracture without any deformity, just like this x-ray, suggest to your attending, Dr. So-and-so, I'd like to do a formal procedural sedation. I'd like to give 100 milligrams of propofol to place a splint. I want you to watch and see what that attending says. I will bring popcorn and we'll wait to see how that ER attending responds to that because that is not happening 100%. Not realistic, not happening.
Perlo, which of our patients can we send on their merry way?
Right. Barry, yoga split lip, moved from North 1 to the hall. Walter, road rash with the rat killing dog, South 20. And Vince, basketball elbow fracture, outside Central 2.
Okay, you can run another set of vitals on Crosby's Papa and discharge. You can tell Ortho to get their head out of their ass and take Joel Embiid with them. And you can release Yoga Barry, but tell him to refrain from doing any handstands for at least 48 hours.
Copy that. Go. You heard the man. I do not know how Dana does this every day.
Running the ER is a Sisyphean task.
So this is a punishment.
No.
Sisyphus. Sisyphus pissed off the gods, so they punished him by making him push this massive boulder up a hill for eternity.
One must imagine Sisyphus happy. You're doing great. Hey, Ahmad. Is Teresa still out in Cheers talking to those cops? Yeah. Will you do me a favor? Just kind of keep an eye on it. Don't let her leave without talking to me.
Okay.
Any word on Driscoll?
I issued an alert throughout PTMC security and called the cops with his home address from his chart. They want a statement from Dana.
She's in CT. Let's clear her medically, and then she can decide when she wants to talk to them.
What about other hospitals? You let them know?
Notify. Everyone's on the lookout for this guy, Tristan.
Thanks, Mark. Got it.
What the hell kind of circus are you running down?
God, you're like a bad penny.
Where is Dana? Who is she?
She's all right. We sent her to CT to make sure.
Did you fill out an incident report?
I don't know. I was more concerned with her having a skull fracture than with your liability.
So I've not been a fan of Gloria this entire season so far. Now, I believe she is the CMO, so Chief Medical Officer. You know, if I was the Chief Medical Officer, my first question would be, how is the nurse doing, right? She just got hit. How is she doing? What is the status of her? That's what we care about, right? You're caring about your staff, and instead the CMO goes, have you filled out the incident report? That already tells you how the CMO is and where that focus is. It annoys me for sure, is that should not be the focus of the very first question.
Guy from the waiting room get back here without anyone noticing.
Wow, Gloria, what a great question. Our hardworking nurses were just asking me what steps the hospital plans to take to ensure their safety in the future. Maybe you'd like to explain to them why you've denied my request for additional security measures 3 times in the last 4 months. If nurses don't feel safe, they're not going to come to work.
Ah, snap. Tell her this is perfect. I love that it's said out loud as well so that everyone is aware at how many times his requests were rejected by her.
First off, the safety of all our employees.
Do you remember the last nursing strike?
Yeah, that was a real shit show.
Maybe this is something our union rep should know about?
Okay, but just take a beat and remember that PTMC is a family. Come on.
Dysfunctional family.
You should be worried about the nurse's satisfaction and the safety.
We gotta worry about everyone. You, Robbie.
Here's your driver's license and insurance card, Mr. Puglisi. Have a seat, and the triage nurse will call you back soon.
Thank you. Hello, my son, he needs help, his eye.
Let me ask you about your eye. Do you see the line you just cut?
No, please, it's an emergency.
You think everybody's waiting for manicure?
We caught a line drive to the eye.
We're so sorry, ma'am. We thought this was the line for pediatrics. I'm 16.
I'm doing this because you're a minor and you have manners.
Thank you so much.
Name and date of birth?
Every young, December 7th, 2008.
I'll get your insurance information from your father. Take a seat.
What? No, we're not waiting. Show her. Show her.
Okay, then. Come around to the double doors.
So finally, I am super excited to finally see an eye case. Now, I did catch that in the out in the waiting room. There's actually someone with a pencil in their eye. Love that. I was really kind of hoping they would bring that one back. But super excited for an eye case. Every attending has cases that they like most. My 2 favorite chief complaints I will pick up every single time are abdominal pain and eye pain. Now, obviously, we pick up everything, but there's certain things that, you know, if you're on with more than one, you know, attending, right? There's certain things that all of us like. I like everything eyes, so very excited to see this. When I was in high school, our baseball team was playing pretty late. No lights were up at all in this particular field. Now, honestly, the umps and coaches should have called the game, and I made the dumb decision to square around and bunt, just with how, you know, first and third baseman were playing. Like, I can get this, I'm fast. And so I should have done that to begin with. But I took a ball directly to the eye, suffering a non-displaced, none of these fractures were surgical, but obviously had some, heal time. So this brings back some memories for sure. And now to see someone getting hit with a ball, I'm like, all right, this is legit. Now, I didn't have to have the procedure, he's going to end up having here in a little bit, but I get where he's coming from. Now, what I want you to do though is look at the image on the screen as the patient's exam is going to change. So I don't know if this was intentional, if this was subtle, if this was just me nitpicking, but I want you to pay attention to the patient's physical exam. If you look carefully enough, you can see him moving his eyes, right? Likely that prosthetic wasn't on yet. Obviously, it's a lot of makeup. He's freely moving his eyes. So we're going to see a little bit later, a little bit different physical exam. And is that because that retrobulbar hematoma is getting bigger? We're starting to have that bulge of the eye. Are they showing that progression, right? I don't know. Now, you're going to notice here, you can clearly see his eye. It's clearly not bulging at all. You can see that surrounding periorbital edema, so awesome job with the makeup, that looks real. You can see that surrounding ecchymosis. As the episode plays out though, you're going to notice that swelling getting worse and the eye appears to be bulging by the time they actually do the procedure, and that's because that retrobulbar hematoma, and that's causing it to lean, push forward. What we're developing is an orbital compartment syndrome, and so that pressure is building up.
So next to place on deck?
All set. She's 62 kilos. 0.25 per kilo is 15.5 milligrams.
Push over 10 seconds.
Status?
Diffusion flare mismatch means she's less than 4 hours into it.
Getting TNK now.
Sounds great. Would you mind hanging down here for a bit? I could use your expertise on this.
Can't believe you have the nerve to ask.
Good one. Okay, keep me posted.
50 on board. Anything I can do to help in here?
Yeah, I'm pretty good. How you doing?
So they started with 50 milligrams of propofol. They have them on the monitor, but again, I would argue this is not needed for a splint like this. We're not doing a reduction. Just give them pain meds, right? It takes only a few minutes to place this splint, and they're not having to reduce it. Just hold it up and place the splint. I don't know one ER doctor that would even do 50 milligrams of propofol, or any propofol for that matter, to place a splint like this on a patient with a non-displaced fracture with no deformity. Also realize how busy this ER is. The moment you choose to do a procedural sedation, you just tied up so much time setting up, the observation period afterwards. You just tied up respiratory therapy. Some of your ER techs that are in there helping with the splint. You just tied up the nurse, additional paperwork to fill out. Again, this is for a splint, not a reduction. For those watching, if you're an ER doc, and you would have had your patient undergo a procedural sedation with propofol, all right, to place a splint on a non-displaced ankle fracture with no deformity in the ER that was this busy, right, with little resources and being understaffed, I would love to hear it, because I think it's going to be absolutely nobody.
Not as good as you, apparently.
Push another 25. Wet the splints now, please. You can help lift his leg for the splint.
And we're at 75.
When we lift his leg, it's really gonna hurt him, but he won't remember benefits of propofol.
Pulse ox 99, good end tidal CO2.
Hey, Chad. Chad. Perfect. Let's do this.
I feel sad.
Don't worry. We'll have you fixed up good as new.
What does he have that I don't have? I mean, sure, he's younger. And that hair.
Who?
Mateo. What's his story, anyway? Is she having sex with him?
Well, if she isn't, she probably should.
Who do we have the pleasure of meeting this afternoon?
Everett Young, 16, took a line drive to the left eye. Tucky at 118.
Oof. 4 of morphine, 4 of Zofran. Excuse me.
It was easily 100 miles per hour.
Oof. Did she pass out?
No, ma'am.
Baseball's a fun activity. You any good?
Any good? He's got a 95-mile-an-hour fastball, a 12.6 slider, a .94 ERA, and he's a southpaw.
What's that?
That's a future Cy Young.
I didn't know what that is either.
Miss Javati is a student doctor. She's a bit of a prodigy herself, actually. Do you mind if she helps out?
No, ma'am.
Okay. Tell me how many fingers I'm holding up.
I can't tell. Oh my God. Oh my God.
Okay, tell me when the light turns on.
Now?
Light perception only. Do you want a portable slit lamp?
Definitely. Javati, what do you think of the anterior chamber?
Hyphema.
Exactly. Grade 4.
You have meaning?
Grade 4 hyphema. So per the Cleveland Clinic, what is hyphema? Hyphema is the medical term for blood collecting in the front or that anterior chamber part of the eye. The blood pools in the space in front of your iris. That's that ring muscle that gives your eye its color. So grade 0, we also call it a microhyphema, so it's super small. There's no blood layering, but blood is visible, though it might require special tools to see. Again, I typically don't say grade 0 because I can barely see this. Now, grade 1, on the other hand, layered blood that fills, less than 1/3 of the anterior chamber. Grade 2, layered blood filling 1/3 to 1/2 of the anterior chamber. Grade 3, layered blood that fills at least 1/2 of your anterior chamber, but doesn't fill it completely. And then grade 4 is a total hyphema, so the whole thing just looks red. So layered dark red or even this black colored fluid completely fills your anterior chamber. There's sometimes, we call it like an 8-ball or a black ball hyphema are some of the other terms that you can use. A patient's got a right-sided 8-ball hyphema. This puts you at a much higher risk for angle closure glaucoma. Again, much different lecture, but what really wanted to kind of show you hyphema, kind of how we grade that in a trauma setting. Again, I'm going to put all 4 of those on the screen for you, actually all 5 of those on the screen for you, to just take a look at, and you can kind of see that progression as we go from that grade 0 all the way up to grade 4.
Chivati, meaning blood is filling up the front eye chamber. He'll need an emergency evaluation by ophthalmology.
Is that why you can't see?
It's part of it, yeah. You see how the eye is pushing out? There seems to be a collection of blood behind the eyeball. The eye pressure's too high. We have to act quickly.
Okay, well, check the pressure.
We're going to right now. Can you get Robbie?
So they're going to be checking the pressure itself. We call this intraocular pressure. Now, a retrobulbar hematoma or bleeding behind the eye can significantly increase that ocular pressure, leading to orbital compartment syndrome, which is the dreaded complication and potential vision loss. Elevated pressure within the confined space of the orbit basically compresses that optic nerve, it compromises blood flow to the eye, and patients go blind. Now, per the National Library of Medicine Stat Pearls, in an article entitled Retrobulbar Hematoma, they state, retrobulbar hematoma is a rare yet sight-threatening diagnosis. Although mild cases may occur, a devastating consequence is the development of orbital compartment syndrome, and that can lead to potentially complete vision loss if not treated promptly. The definitive management is lateral orbital canthotomy and canthelysis, which can be vision saving. So when you look at this image, when you look at the patient's image in this particular TV show, the eye is supposed to be bulging like they're saying it is, but it's not. I don't think it's just portrayed correctly. I think they either need the prosthetic on there at this time or just to really make it appear that bulge. I'm going to put a few on the screen for you, but we should be able to see that bulge. And when you're at that point, in general, there's going to be pretty limited ocular movement on quite a few of these that I've had just because of the swelling in that bulge. This is a patient with periorbital edema, ecchymosis. We know already having some vision issues. So they're really trying to show us that developing retrobulbar hematoma. But then you watch the patient, he's just freely moving his eye, right? And I'm like, wait a minute. So again, we're going to talk about that here in a second. I think if they wanted to change it a little bit, give us a little bit more of a bulge. In addition to that, make it so he's not really moving his eye. In numerous scenes when you watch it, he's just moving his eye freely, which you're just not going to see in this situation. So I think that just needs changed a little bit.
You a junior?
Yeah.
You thinking about college?
I have some D1 interests. Where'd you go to college?
PITT for undergrad, not med school.
You want to leave town?
Look up at the ceiling for some numbing drops. It's not exactly an option to live anywhere but home when you go to college at 13.
Wow.
Add some drops to the fluorescein strip.
I was thinking about California. Maybe UCLA or USC.
Still?
Hey, maybe you go straight to the majors, huh? College can wait.
So here she's placing a topical anesthetic eye drop, like proparacaine or tetracaine are very common ones we use, so she's using likely one of those. Next, she actually used the strip, and we call that a fluorescein stain strip or a fluorescein strip. So basically, it's this white strip, and then it's got this orange area on the end of it that has the stain. And basically, that allows a few things. Now, if there is a corneal abrasion, the stain's actually going to go into that abrasion, and we can actually see it underneath the light. Now, if there's an issue with the anterior chamber leaking aqueous humor, we can then see that fluid just light up on that stain as well. So kind of a few things.
I don't know.
I do. Ev's got a God-given gift. That's why we spent every weekend doing travel ball when he was young, pro camps, showcases. He's not throwing away his shot at the majors.
We have to check for the puncture before we can measure the pressure.
When she says she is checking for the puncture, what she's actually talking about here is the Seidel sign or the Seidel test. I love this. And I'm actually going to put a video on the screen for you so you can actually see what this looks like in real time. So basically, you're using this test to make sure that there's not a globe rupture. That's the big thing, because you actually do this before you check pressures. You have to do this. The Seidel test or Seidel sign is used to identify full thickness defects in the cornea or sclera by revealing that leakage of that aqueous humor. So per EMRA, the Emergency Medicine Residency Association, the slit lamp with cobalt blue filter or Woods lamp can be used in combination with fluorescein dye to evaluate the cornea and conjunctiva for defects. If there is suspicion for a corneal perforation, the Seidel test should be performed. This is done by painting the lesion with fluorescein dye. If the dye is displaced inferiorly by fluid moving away from the lesion, right? So I typically will put it in and then I'll lay them flat and then actually sit them up. It really depends on what equipment you have. You just have a light? Do you have the full thing? So it really depends on kind of what you have, but that's what I like to do. And you can see the dye being displaced inferiorly and that fluid moving. So it goes on to say the test is positive for perforation if you see that movement. Overall, it just needs to have a good stain to be able to see it. And you want to be able to know if you have a positive test before you actually go and either push on the eye or check the pressure. So we'll talk about that in a minute.
Straight ahead and try not to move your eyes, okay?
Yes, ma'am.
Lights going out.
Hello, I'm Dr. Rabinovich. Everybody calls me Dr. Robbie.
Hey, Greg Young. This is my boy Everett.
Nice to meet you both. Okay, I will take that slit lamp and you can calibrate for tonometry.
Okay.
They're holding CT for him.
Let's take a look. Negative Seidel. No globe rupture. Okay, go with the Tonkin.
So we hear the Seidel test is negative. Now, we know that there's no globe rupture. Now we can check pressures of the eye. This is when it's done. You can imagine if there was a globe rupture, right? There's a hole in the eye, you're leaking out fluid, literally a hole in your eye all the way through. And then you are either tapping on the eye or in this case, they're going to check pressures and you can actually see them touch the eye. You can imagine the damage that that could do. It's actually contraindicated in a globe rupture to actually check intraocular pressure. So I do like in the scene, I was getting ready to critique it. I thought they were going to do one before the other, so I'm impressed by that. They went ahead and checked with the, they stained it. They, checked for the Seidel sign, the Seidel test. They made sure there's no rupture before they actually checked pressure. So I love that.
Hold still.
Okay.
Left eye pressure 58.
So left eye pressure is 58. Now, the normal range is between 10 to 20 millimeters of mercury. My issue with this is that visually watching this from home on the screen, again, I don't see a bulge. The patient's moving his eye freely. There's no reason to think the pressure is this high at this point. I would have believed if they would have said pressure's 35, I'm like, oh, that explains why his pupils are still moving. I can see that swelling. That tells me I'm starting to have that increased intraocular pressure. I'm likely, have an underlying retrobulbar hematoma. If this continues, it's going to be pain. It's going to be he's not moving his eyes. It continues. Now we have the development of orbital compartment syndrome, right? It's that whole spectrum. When you're at that point, obviously you're not doing a CAT scan. They just need cut. Now, everyone is obviously different. I just think that with this scene, the eye could have used more makeup or even a prosthetic eye to give that bulge. Now, with how they make the eye look with a pressure of 58 to give that appearance, needing an emergent lateral canthotomy, needs done as soon as possible, is just not realistic. When they do the procedure though, that is terrific. So wherever they got that prosthetic, however they did that, looks awesome. And so that was done very correctly. That looked good. So we'll talk about that later.
Is that high? Yes, it is. 1% lighter with epi, push 1 over set, and open a lateral canthotomy trace, excuse me.
What? Whoa. Without a CT? Isn't that...
Exactly what the patient needs? Yes, it is, Dr. McKinney.
Okay, we're gonna lie you back, little Everett, okay?
We need to do a little minor surgery to relieve the pressure behind your eye, so we're gonna cut a small opening on the side of your eye, not in your eye. Got it? Yeah. You wanna watch?
No, I'll sit down.
Your body, step up so you can see.
Dr. McKay, Chad is splinted, is awaiting ortho for surgery to take him.
Thanks for the update.
First head's on board.
Numbing medicine here, okay? Okay. Pinprick and some burning.
So I just wanted to pause here to at least, provide a little bit more education on a retrobulbar hematoma. And when we get to part 2, we're going to be talking about that procedure a little bit more. I will say, when it's advanced to the point of orbital compartment syndrome, like when you're at that part, right, that canthotomy should have already been done. That's too late at that point. We're trying to catch it as it's developing, and I think that's the big thing with this, but it's trying to portray it accurately developing, making sure everything is there. You're essentially catching it as it's developing. So in an article published in the National Library of Medicine Stat Pearls entitled Lateral Canthotomy, it states, orbital compartment syndrome is a clinical diagnosis. The risk of irreversible blindness is great. Any patient with facial trauma, infectious process of the sinus or orbit, concern for retrobulbar hemorrhage or hematoma, or recent ophthalmologic surgery who presents with proptosis, so bulging of the eye, decreased visual acuity, which the patient did have here, elevated intraocular pressure, reportedly was 58, restricted extraocular muscle movement, his weren't restricted at all, and or afferent pupillary defect should be considered for emergent lateral orbital canthotomy with canthelysis. So intraocular pressure, it goes on to say intraocular pressure measurements of 40 or higher indicate a soft threshold for intervention. For patients that are unconscious with periorbital injury or who are unconscious and unable to give a history or describe their symptoms and participate in a physical exam, an emergent lateral canthotomy is indicated. So again, in this patient, they stated proptosis. It's hard to see any proptosis at all. He looked like he had zero proptosis. Visual acuity is decreased, so they did mention that. They tried to give us that increased intraocular pressure of 58, that was mentioned. And in terms of restricted ocular movements, restricted extraocular muscle movements, no patient was freely moving that part of the eye. So I think at this point you can see why things did not quite correlate. Now, I would have given the patient, the same looking eye at the time of evaluation as the actual procedure. That's what they needed. Whatever they did to get to that point, they needed to give that to him on arrival with that same pressure, with all of everything that was done. I would have did that procedure for you. I'm like, let's do this. Let's just get this over with right now. Again, very subtle, but I wanted to point that out before continuing further. Now, part 2, we're going to cover the remainder of episode 10, and I'm going to be taking a deep dive in the procedure itself, in addition to putting an actual procedure on screen for you off YouTube to be able to watch. So again, fun procedure to do, but until next time, I hope you love this review, and next up is part 2.